Well, I'm going to change speed a little bit, and when we bradycardia pace people, it's usually because they are symptomatic, they've had syncope, they've got chronotropic incompetence. Sometimes, as we've just heard, you do it prophylactically because they're at high risk of syncope, so you try and preempt it or prevent it. I'm just going to talk about defibrillators now, and defibrillators really boil down to two categories. There's the easy decision, it's the so-called secondary prevention. That is, somebody's survived a cardiac arrest, a hemodynamically unstable ventricular tachycardia, they've got structural heart disease, they're at very high risk of recurrence, so we offer them implantable defibrillators to save them from their next event. The problem, though, is that a secondary prevention really means they've got to have identified themselves. And as we all know, if you have a cardiac arrest out in the community, your chance of being found, resuscitated and successfully getting to hospital and surviving to discharge is actually quite poor. About 25% get to hospital, and only about, depending on the circumstances and the country and the services, probably only 10% would get to leave hospital. So waiting for that event to occur is a little late for many patients. And I can show you slide after slide after slide of evidence to say, well, implantable defibrillators are useful, and Class 1A evidence is the strongest evidence for certain categories. But what I really want to chat about today is the so-called primary prevention. That is, trying to identify patients at risk of suddenly dropping dead with malignant ventricular tachyarrhythmias before it happens, and implanting a device in them so that they're prepared. And let me just run through a case which I think highlights the issue. This is one that Wayne Stafford looked after about 10 years ago now, and it's a fairly typical patient that comes along to see us and you and your clinics on a regular basis. He's got a severe dilated cardiomyopathy, his left ventricular function is poor, but he's stable, he has no symptoms of heart failure on ACE inhibitors and beta blockers. He's really doing well, feels great, doc, happy with everything. And Wayne at the time said, look, you know, he is well, he's on appropriate medical therapy, but the other big risk besides heart failure in poor left ventricular function is the risk of malignant ventricular tachyarrhythmias, that is VF or VT and VF arrest and dying. And he actually spoke to this gentleman about this risk and said we could offer you an implantable defibrillator based on very good trial evidence at that point that this can actually save your life. And the patient, feeling well, said, thanks, doc, I appreciate the chat, I understand everything you've said, I'll think about it next year. And of course, the next little email we get from our secretary is the wife's rung in and said the patient's deceased. And this is the problem. These are perfectly fit, healthy people. They've got cardiac disease, structural heart disease, but they've got controlled heart failure. They're feeling well, and all of a sudden, out of the blue, they get a malignant arrhythmia and they drop off the perch. And we can save them from that, get them up, dust themselves off and get back on with life. So the vast experience from multiple trials, the MADIT trial, the SCUDEF trial in the early 2000s, tried to identify people at high risk of these. And we know the simplest algorithm, after many, many trials of electrophysiologic testing for VTs and everything, the simplest algorithm is what is their ejection fraction. So in simple terms, if somebody's left ventricular ejection fraction is 35% or less, they have a significantly higher risk of malignant arrhythmias and will potentially drop dead from those. So let's look at a second example. This is a 46-year-old man, previous infarct, he's on appropriate medical therapy with ACE inhibitors, beta blockers, statins. He's asymptomatic, his lipids are well controlled, he's got an extensive regional wall motion abnormality on echo, EF is 30%, no inducible ischemia on functional assessment, he's feeling well, very functional, 46-year-old, enjoying life and functionally a good member of society paying taxes. We spoke to him about an implantable defibrillator and he said, yes, please. And 4 years after that implant, he was with his son at a campfire on a school camp, toasting some marshmallows, and he collapsed. And this is what happens. Perfectly well functional, out of the blue, something like this happens. Now, when we go back and interrogate the device, in its memory, here's what happened. And you can see these electrograms, the top layer is the atrial activity and the bottom is the ventricular activity. And what's very obvious is that there's a lot more ventricular beats than atrial beats. So it has to be ventricular tachycardia. There's no other explanation for that. So he's gone into ventricular tachycardia, toasting that marshmallow. He's blacked out, but the device has recognised this. It's charged up. It's given him a single shock right here, and you can see restoration of sinus rhythm with atrium and ventricle steady, regular rate. He dusts himself off, enjoys the marshmallow and gets on with life. He and his family are very thankful. And this is what could have happened for the previous patient had he said, "Doc, I want that defibrillator put in." So I just wanted to highlight this. These are patients that are actually often very well out there in your practice, but they are deserved because of the high risk. This has been validated in multiple trials. And just to think through an algorithm when you do see your patients, if they've got coronary artery disease and their ejection fraction is less than 35%, and this is not in the acute phase, the first month or two after an infarct, but this is stable later, then they would meet the criteria for an implantable cardioverter defibrillator. And Michael's going to talk about specific roles for biventricular devices in a moment. And if they've got a non-ischemic cardiomyopathy, again, less than 35% on appropriate medical therapy, they meet the criteria. Because these are people at high risk of malignant arrhythmias dropping off the perch. And not only is this generally in guidelines around the world, in Australia, overseas, it's part of the National Heart Foundation guidelines in Australia about the use of these devices. And as it is endorsed by these guidelines and ratified by the government, because the item numbers, the MBS item numbers reflect this, we can implant these reasonably expensive devices in this patient population because of the known benefits prognostically and the economic value in that. So I just wanted to put that out there. Secondary prevention is pretty obvious, people that have survived it. We do have other primary prevention indications which are rarities, things like long QT syndromes, Brugada syndromes. We'll look after those for you, but in your practice there's probably many, many patients with stable coronary heart disease, stable cardiomyopathies, with EFs less than 35% who are at risk of these arrhythmias and deserve it of consideration for device therapy. Any questions? I'll put them to sleep, Michael.
So, you talked about the Class A evidence. So, how many of these ICDs actually go off? I mean, what percentage of these patients are actually going to benefit and also survive and live to tell the tale if it does start?
A very good number. And if you actually look on the number to treat, and all of this has been thoroughly analysed in the studies to validate not only their clinical utility but their economic utility, and you actually find that the number to treat, I think, depending on which class and which underlying disease, is often like 7 implants to save lives. And it's very cost effective. It's much more cost effective than chemotherapy, than dialysis therapy as far as saving lives and prolonging life. And if you look at patients the other way around, those that we've implanted these primary prevention devices in, when they come back to follow up over the course of many years, you'll find that there's somewhere around about 15 to 20% annual discharge or therapies for ventricular arrhythmias from these devices. So it's not too far off the actual annual use of a device for secondary prevention populations that receive them.
I have had the unfortunate experience of a patient in Gympie who died for other reasons, but of course this kicked off and kept going, kept constantly trying to bring the person back to life and had to be transported to Nambo before it could be turned off. So you must have the stress of the relatives. So apparently there's a device to turn them off and should be available in all EDs. Is this the case, and should this be the case?
I think that there's probably a little more to the story. I didn't go into huge details, but if we're going to offer these primary prevention devices to patients, we've got to have a reasonable expectation of the rest of their health and their morbidity and mortality is reasonable. So you wouldn't put in somebody with a terminal malignancy. You would expect that they're going to live longer than at least a year or two to reap some of the benefits. There are many of our patients, they've had these in for years and they're ageing, and now they've got end-of-life decisions about comorbidities. They've got terminal cancers or what have you. And so we'll often have discussions with families about switching devices off because they actually want to go quickly and quietly from a malignant arrhythmia. That's a peaceful way to go at the right time. So we can proactively manage that. If somebody goes into ventricular fibrillation, the device has a preset number of therapies and it will then reset. So it will normally discharge 6 times, and if it hasn't terminated, it will stop. If it's repeatedly going off through that ambulance trip, then he's probably going in and out of the rhythm repeatedly. Now, that may not be what somebody at the end of life management wants, so we would have preferred to have switched it off before it gets to that point. But nonetheless, when they get to the emergency departments, we can certainly have, there's programmers around, if not one of the technicians can bring them and switch the devices off. Or you can inhibit temporarily in the emergency room by putting donut magnets over it, and it'll stop the therapies there and then. So there are ways to manage that unfortunate event, but it's pretty rare, I must say. Well, I guess as I get more senior, they all seem younger and younger. Look, I will tell you that the trials were all done, the inclusion criteria were in patients of up to 80 years of age. So these primary prevention trials were not done in over 80s octogenarians. So we would normally have a lot of reluctance. We'd be conservative about offering it in that population. If they were a really good 80-odd-year-old, you'd think about it, but we're still relatively conservative in our deployment there. If somebody had recurrent VTs and they were 85, we have to manage that, and we would put a defibrillator in, but these primary prevention indications, we're a bit conservative over 80 years of age. Some of our colleagues, particularly over in the United States, age is no barrier to anything, and they keep putting them in at all ages. But I think practically speaking, and perhaps tomorrow's discussion about cardiology management in the ageing population is an area we can talk about this more. But I tend to use 80 as a cut-off. I don't know what my co-members of the panel think.
Yeah, I think that's a very good question. But I think overall that as for me, I look at more on the biological age. I mean that what's a patient actually function rather than what the actual age. That's number one. And number two, that it's quite often that before a discussion on defibrillator, we actually went through quite a lengthy discussion about what's his view of end-of-life issues and things like that. So it's not I mean, of course, that John actually tried to summarize everything, but the discussion and the decision actually takes quite a lot of discussion usually.
Yeah, I agree. It'd be very much patient-specific. Patients, you'll meet 80-year-old patients that absolutely want a defibrillator, and 80-year-olds that don't. And some of those 80-year-olds will live to 100. And so it's hard to put an age criteria. There is no age criteria, but it's very much patient by patient.
Yeah, it is difficult. The GP's role in this is actually probably under-recognised. The discussion is a group discussion, I think, in the older patients. I will, in my own practice, try and steer people down a path of what I think about the topic, but sometimes it's raised with them, or another cardiologist may have seen the patient and raised the issue because they've seen some VT, and patient's family do reading about and know about the therapies. I think we have to be very careful that you have a discussion rather than choose to bury the discussion and then potentially leave yourself open to complaint, and there's survivor guilt issues and so on. I had a patient, I can tell you about an unfortunate case that of a patient that Liz had referred me many years before the event, who'd had non-sustained VT and an ejection fraction of about 40 to 45% related to coronary disease, who does not fulfil criteria for an ICD, but you'd be concerned. We did an EP study and could not bring on VT in this guy. So we thought, okay, we'll just treat him medically. And his LV function slid and he developed left bundle, and we'll talk about it in my talk soon about putting a CRT system in, a resynchronizing device. And so the issue is, do we put it now in the guy who's now turned 80, a biventricular device, he's not had syncope, no further VT documented in a major way, or do you put in a biventricular pacemaker? And I spoke with the family and I said, look, I think with the EP study that's been done before, we might improve his ventricle with the resynchronising, we'll put a pacemaker in. It happened only, I think, 2 months after implant. He had a cardiac arrest at home. His wife delivered CPR. It was terribly traumatic for her. You can imagine what the quality of CPR from an 80-year-old wife is likely to be. He's never been trained in CPR. It was, as expected, poor, and he had a poor neurological outcome. He was resuscitated by the ambulance service, and so that's a decision that I sort of look back on it with some regret. And the guy's 80, and yet it was a really traumatic outcome. He survived through all of that, and then, then there's the discussion about does he have an ICD, and I tried to steer them away from an ICD at that point because he had profound cognitive impairment and so on, but the family could not deal with that, and he actually chose to have an ICD that another colleague put in. So that was a pretty unsatisfying sort of sequence of events, and so it's easy, I think, to draw lines in the sand about a particular age, but it's a case-by-case decision, and I think we welcome your involvement in the discussion of these things with the family, because they sometimes have not met us for very long.
Like all medicine, hindsight's wonderful.
Start the what, sorry?
Interesting.
Yeah. I think that it's a separate, so that the devices, I mean, we're all device implanters and believe in the technology, but these devices are complementary to medical therapy or adjunctive treatments. They're not substitutes for conventional medical therapy. So it's a given in all of this discussion that in our patients with LV dysfunction that they'll have optimal medical therapy. And the issue in terms of those that are later, whether that should be ACE inhibitor ARB or now the combined, we're still grappling with the decisions, I think, as cardiologists about the role of Entresto at the moment, and that we've got one big trial that's very favourable, but the drug yet, it has access on the access scheme. I think in time, the heart failure, I'm not a heart failure expert, the heart failure experts have still got divided opinion on this as well. So at the moment, I think the consensus is that if people are doing well, we're sort of not necessarily switching, but if people are on a bit of a slide, we'll probably move to the Entresto.
Can I just reinforce that these primary prevention trials were all on medical therapy. So, and as you saw the two cases I showed, they're on beta blockers and ACE inhibitors. So the ICD benefit in prognosis is above and beyond the medical therapy that we expect them all to be established on. All right, we'll let Michael go on. Thank you.